that's it, those two, that's perfect, thank you.
I don't see any questions coming through, but I will just close the door.
So last time, that's true. The system didn't work and I had to go to PowerPoint, but this time, this one works. LibreOffice and not PowerPoint, hopefully, we'll see. Here we go, presentation skills, effect practice CQC ratings. Didn't do very well last time, so I don't know, I can't juggle stethoscopes or anything, so we'll have to do our best. This is what I told last time, you may have seen it, maybe the presentation, that yes, we had a slideshow and we thought everything was great, but it said also that you would know upon entering what sort of results you're going to get. So I don't know if it's all going to be of much use, but there you go. Last time the presentation, 38 slides, we gave a history of the practice, how the building is developed here. Then we had slides on that we had the highest rate of allocations for 15 years. We were the only practice covering the ward here behind, and still we had the highest satisfaction ratings in Kent. There's some slides on the investment and the money and the sacrifices we made. When I started here, I came from a practice down the road. It was a lot more affluent area really, and it's completely different way of working. I think there in the 5 or 6 years I was there, I think I used half a sick note pad, and here was through one within 2 weeks or so. So we worked and we changed the building. There was no money for the first few years, and once we had it, there was no money for plumbing and electricity contracts, so I spent a lot of weekends here trying to improve the place. And so the reason why I came here to a deprived area from an affluent practice where I was making a lot of money, much more money I could spend, is because I was not happy really with the quality of care that we were providing. There were waits for patients, they had to wait a week or two to see me, they had to wait 4 weeks or so to see the practice nurse. And I thought we could work in a different way and on a more personal level, even though it means working hard. Yeah, we had some slides on the things. I think you managed to get around everybody now. And then we had some slides on the intelligent monitoring tool. I think last week or the week before we got your new report in, and there have been some changes, so we probably don't need to go over it again. That was the amount of antibiotics. I was trying to make the point that if you have antibiotics, and there's good and bad antibiotics, the pears are not very good apples, they're bad apples. So if you're worried about the amount of bad apples going out the door, then you can just look, because you know from the calculation you make percentage-wise how many. There's just 2, so you could just compare that. I think in your new tool now you're looking at the total amount of fruits and antibiotics going out the door. There's a slide I made up for saying patients. This patient is smoking. How much are you smoking? 50%, doctor. 5 pints. This patient also smoked or drinking 50%. But anyway, you've changed it, so you don't really need it anymore. Then we get this in here with your latest report a week or 2 ago, saying that if there's any problem with the data, that we somehow have to be responsible for that. And I think, you know, if you're putting out reports, then you should take some responsibility for the data that you use. I've had loads of emails, loads of them, with your intelligence monitoring team that you're probably renamed now, saying, you know, that if you're using those data, you have to look at it. And why am I spending hours and hours of time trawling through spreadsheets trying to find explanations for problems in the data that you're using? If you're using it, use good stuff. Anyway, that's a new report, intelligence monitoring, now called Insight. I think I must say I'm very impressed with it. It's much better. Here, for instance, you've got the problem indicated there below standard for percentage of children age 2 with pneumococcal. and then you put a link there where it's highlighted. So you can click on it, check the data. Excellent, well done. This is what you get when you look on the thing and open the file that you get the data from. I can see here, what pointer works? Oh yeah, so that's our practice here. Take my word for it, the 82175. That's the 2-year-old targets here. So they get at the 2 years, have been reliably informed by a nurse. That they get 1 year MMR and then a PCV booster. And so 95% of the patients thereabouts have had their MMR, but apparently none of them wanted the PCV booster at the same time. They said, no, don't have it. How is that possible? I don't know. But if you look through the whole data here, the whole data here is very, very weird, really. If you look at it, you think that's not right. And actually, if you look about 10 lines below, you see another practice here, Y12505 or something, I think. Or it's this one, 2506. And you see here that they have a similar thing. They get 95% on people having MMR, and then 7% of those only having the PCV, the pneumococcal booster. So again, a very strange group of patients that said, yes, we'll have the MMR, but no, we don't want the other one at the same time. Which is weird, because the rest of the country, it's about equal. If you put it in Google, you come up with this here, NHS Sheppey Healthcare, DMC. That's the second practice here. Now, the only thing we have in common with them really, because they're in APMS practice, the only thing we have in common, we use the same clinical system, System 1. So there's some problem with the data upload already from System 1. So probably if you look through it, and if you bother to look through the files, you'll probably find another few practices, and if you look at it, they probably all have System 1 clinical system, where they're coming up below standard. If you scroll right to the bottom of that 8,000 row or whatever spreadsheet, you get to this thing here, which is also included in last time, that they just produce these spreadsheets, but irrespective of any data quality concerns. So, I don't know, Dave Gorman, anyone? No? Maybe you have to stay in more. He had one of his comedian on Dave's channel, and he had a thing about sort of our moral compass and things, and he had a slide up and saying WWKKD, what would Kim Kardashian do as a guidance to what we should be doing in life. I grew up a little bit longer ago maybe, and I had a sort of idea what would George Orwell do. And so what should we do with the patients that have refused the vaccination of the PCV? I don't know. I think George Orwell suggested we tie a cage with rats or something to their face, but I don't think it's right really. I mean, even if this were correct, and even if the patient had refused these vaccinations, why are we somehow being marked down on that? I don't understand it. I don't know. Can you explain it? No? Probably not. So there's some other problems I have with registers, and so probably the Orwellian experience of the current NHS. And so some things we don't do out of principle, maybe. Maybe my principles are wrong, I don't know. But we haven't ever had registers for homeless, ethnicity, travelers, things like that. I don't think it's right to have registers. I grew up, I suppose, in Holland. That's where I graduated, and even in the 60s my parents had been through the war, and there were registers of certain people that were targeted, and unless we know, I think, what is happening with these registers and what they're being used for. Once we have them on our system, they're uploaded, and so maybe sort of inherently, maybe the whole of Europe, maybe that has been occupied at some point, is maybe a little bit more inherently suspicious of authorities. Anyway, maybe amongst those list of of target groups that are not really for medical reasons. You know, why are we keeping ethnicity or house ownership status on a list? There is no. I can't think of any medical reason to do that. I don't know if you have any medical reason to keep lists of people for these things. But maybe I thought maybe GP, single-handed GP should also be on the list of threatened species. The days of the single-handed GP are over. So when you put things like that in interviews, then you start to wonder, where does a single-handed GP, you know, are you coming in really from fresh? You say, okay. I had a look on your website and looked at the GP practices and the ratings, and there were about 6 or so in the last month that we found inadequate. And all of them seem to have some things in common. One, they're all small practices. They all have doctors with foreign names and foreign graduates. And they all mark down 2 things. One of them is well led. Now what you say in your handbook is that a well-led practice should assure the delivery of high quality, personalized care, learning and innovation. We're the first practice in the UK to taping all the patient consultations, also for another reason, and promotes open and fair culture. Right. So I think we're doing all those things. Safe, again, we're doing all those things. But all the practices, and I had a look at a few of them reports, you're thinking, you know, how can you have a practice on a few of the reports that's been marked down, found inadequate? Well, I know there's another practice down the road that had out-of-date defibrillator pads. It's not mentioned in the report. I know there's another practice down the road who produced a report. They didn't have a defibrillator, they didn't have staff training records, they didn't have this and the other. Not inadequate? No. Requires improvement. So it's a mystery to me. It's a complete mystery how one practice is rated over the other. And if I look at some of the reports of the other inadequate practices, you look around and you think, you know, why? Because there's other practices being found good or require improvement that have a lot more problems by the looks of the report. But that's just me. Maybe I don't understand it. This here's a list of things you wanted for today. We've been working on it. I missed the first email, at least I didn't scroll down to the right bottom to see what you meant to send up, so sorry about that. Alison came across the letter, I think, on Sunday, the paper record. Then we had a look and we tried to organize it this time so that we have everything like this in one file, and then we can embed anything that's there. If it's anything missing, it'd be a bit easier to provide the information again next time. But there's a number of things on there that I either don't understand, and so maybe you can give an explanation of them. Details of your policy, protocol, review policy or scheme. Policy, review policy. I didn't understand that. I don't know what that means. But I'm only brought up as a doctor. I haven't done any courses in business language or that. What does it mean? No?
It means there's, some practices have a written policy to say that they're going to review their written guidance policies or written protocol policies on an annual basis or in response to changes in practice.
Right.
So some people formalise that by having a written policy to say they're going to do it. Some places don't. Some places have a date on their policies to say when they were produced, and another date on their policy to say when it's going to be reviewed. It's just 2 different ways of evidencing that you're actually keeping written policies and protocols up to date.
Is that what I've seen on the CQC policies? It says, you know, usually gives a date about 3 years or so in future for any policy. Okay. Copy of our emergency procedures policies. Emergency policies. Again, it's complete blank. I draw a complete blank on this here.
So this is things like what do you do in the event of somebody having a cardiac arrest in the practice?
As a policy,
are there any written guidance for staff on who does what?
Oh, right, it's not a policy then, it's like a plan, maybe. You mean, the plan I understand, policy I don't understand. You know, if we have a policy, what we do, usually try to do the best thing as a policy.
Well, some places have policies, some places have procedural documents, some places just have a diagrammatical sort of representation of who does what in an emergency.
No. I mean, there's a problem a little bit, I think, with small places like us, because we don't know who's going to be on site. And it could be one person, it could be two people. So it's always going to be improvisation at that point, what is going to happen. I don't think we can write a policy of what would happen in each and every occasion. I don't think it's going to change what is going to happen. And I don't think it's very good use of time anyway. So the things I'll run through the other things: safeguarding vulnerable others policy, safeguarding vulnerable children policy, whistleblowing policy. I think I've been reliably informed by a manager we got something like that. Chaperone policy. I think we have something like that. Yeah. Okay. Infection control policy, that age as well. Copy of my medicines management policy together with any audit results. Again, I sort of completely blank on that medicines management policy. Any think what does it mean?
Some practices have repeat prescribing policies for staff, for staff to follow. Various other guidelines.
Procedures for medication. Right. Prescribing. Yeah. I said I didn't know what it meant, so I probably haven't given the right answer on that. Copy of the complaints policy, or the audit results. Copy of confidentiality policy. Confidentiality policy. Again, I don't know. Have we got anything like that? Probably not. Do we? Okay. Apparently we do have it. I don't know what it means, so it might not be correct what we have. Consent policy, I don't think we got that.
Well, if you remember the email that I sent you actually said if you have them, I wasn't expecting you to have everything on the list.
Well, so if I don't know what it means, I can't provide it, so that's why I put them in sort of clarification really. And human resources policies, plural. Again, I think we knocked off some things, but they might not actually be policies. Health and safety policy, it's equality and diversity policy, that we totally have on. Governance policy, information governance and clinical governance policy. Again, I'm not quite sure what that means. I don't even know
my
what...
details were on the email. You could have contacted me to...
Well, we were working on this on Sunday, I think. This Sunday. I think I finished it at... I don't know when the email was sent. 7, 8 o'clock in the evening?
2 weeks ago.
No, when I sent the reply.
Oh, when you sent a reply to me?
Yeah, that's when we were working from Saturday morning to Sunday night, probably 7 or 8. And I don't know, maybe we're in the office checking emails. But that's when I came across it. So I said over the weekend we've had to sort of make policies and things. It might not be correct. It's just I was trying to get some clarification so that if you say this is not right or you haven't provided this, that we at least know what we should be working towards. Business contingency, again we have a plan but not a policy, but it probably means the same thing. Serious untoward incidents policy, staff files and training records. I think that is all in hard files. Staff survey results. I mean, we have 3 staff. I don't know, probably if anybody answers a survey, I know exactly who they are. So it might not really apply to small practice. Staff meeting minutes in the last 3 months, clinical meetings and things. I hope we provided the right stuff. Staff rota for last 3 months. I don't think we have a staff rota. We say if we haven't got it, fair enough. Copy of the latest cough monitoring report. We don't get, as far as I know, cough monitoring reports with action plans. The cough is really a voluntary thing that you can or cannot or don't necessarily have to join. And it's really data collection. I've had a bit of a problem with that since 2004. One of the 20% of the doctors that voted against the introduction of the new contract with democracy rules. It doesn't necessarily mean that I subscribe to spending all our times in polishing data and getting information on the computer. I think there's probably more important things that we should concentrate on. So again, I don't know what it means. I don't keep an eye on that really. Infection control risk assessment with action plans. I think that's fire risk assessment, Legionella risk assessment, risk assessments, other things, cleaning schedule and cleaning records. We've sort of looked into that, so again we've submitted something because we don't really keep cleaning records because we have constant oversight here. So maybe for a bigger practice might be appropriate, probably not appropriate really in small places. Again, we spend more time recording things than actually doing things. It's not the right way to work, I don't think. Waste collection, refrigeration, temperaturing, medication reconciliation records. Again, I'm sort of blank on that. You know, does it mean anything, or have I missed here? Medication reconciliation. That's
normally that would be whatever drugs you keep on site, including immunisations. A record of those that you've received, those that you've used, and those that you've destroyed or returned to the supplier. I don't know what you carry here. I assume you carry immunisations, such as childhood immunisations and influenza, and you may carry other medications, like emergency medications or short supplies if the pharmacist is closed. That's what would normally be included in medication reconciliation records.
What's the purpose of that? Is that just in case somebody swipes the controlled drugs out of the cupboard or something?
Well, if you carry controlled drugs, then certainly that's at the next level above. But for all the other drugs, it gives you a record so that if a sufferer's reaction drug, you know who your supplier was, what the drug references were, and so on and so forth, so that you can say, well, I got this from this particular place, and then your risks are shared with the supplier of the drugs. And then it's good practice, as you rightly point out, for CDs, but also for other drugs, in case things go missing, so that you know what's happened to them. That's the sort of thing that might be included in that.
So it's traceability, but that wouldn't be a problem if we, because we can just go through the accounts and find out where we bought items, if anything ever happens, and the batch numbers would be recorded in the patient records. But I can't really see why we would be spending extra time on keeping extra records that are, you know, never going to be used really. But I don't think that's, you know, there's probably more important things we should be doing. That's my opinion. So there you go. Emergency equipment checklist and checking records for the last 3 months. And we updated a bit. I'll come to that in a minute because we had some other slides. Prescription pad monitoring records, we're doing that as well now. Patient satisfaction survey results, but we haven't really been doing any patient satisfaction surveys since it was dropped from the GMS contract. I think it was probably 10 years ago, or maybe longer. We had a lot of them that we did every year, and they always gave the same results. So again, it didn't really seem that much use doing that. But where you can usually see what practices are doing is independent, is the GP patient survey. It's been done independently, can't be manipulated by the practices. It might be a better guide of what's going on, but I don't know if that's acceptable to the CQC. Maybe. Participation group meetings, accident incident records, SUIs, practice plan, business plan, strategy and objectives. I don't think I've ever written anything like that. Do you think this is essential? I don't even know what it means, so we probably have to start from there.
Well, you sent me a link to the presentation before for that, didn't you?
Well, yeah, I mean, providing the best care we can within the resources. I mean, but I don't know if I need to write that up really. That should be evidence of what is going on. Visions and value statement. Again, I can't see myself spending time on writing down the obvious. It seems a meaningless activity. Maintenance records of building and equipment for last 12 months. So I think we do have a spreadsheet. We keep an eye on equipment, etc. I don't know if that counts as sufficient. I don't know what it means. And if you have it, the number of patient long-term conditions. I don't know exactly what long-term conditions mean, but the rest of it, I think I took some screenshots from the cough pages for the registers on learning disability, depression, mental health, dementia, homeless patients. Again, probably out of principle I would not keep a record like that. Patients in nursing and residential homes, I think we need to run a separate search for that if you want them. I might be able to think of most of them actually. The number of patients who are also carers, again, I can't see why we're keeping a record of carers because it doesn't make any medical sense to me. Diabetes, asthma and things, yes, we need it for recalls, we need it to check medication, we need it to help the medical care we give to patients, but I can't see why we would need a carers speak. I didn't even know what the carer is, but there's different links here and different definitions depending a bit. The first one is from nhs.uk. Care is someone who helps another person. Then there is a carer as anybody who looks after anybody who needs help. That's the England.nhs definition, and I found it on your website as well after a bit of searching. A person of any age, including children, who provide unpaid support to a partner, relative, friend, neighbour, or couldn't get by without their help. That's your definition of it. But I can't see why. So,
I think the reason why there's a lot of emphasis placed on carers is generally there's probably about 10% of the population who are carers in one form or another, many of whom don't see themselves as carers.
Yeah.
And with the changes in the Health and Social Care Act, a lot more emphasis and support is given to carers, because quite often, because they're so involved in caring for somebody, they quite often neglect their own health needs. So that's one of the reasons why you're encouraged to identify carers.
Yeah, I looked on your website and yes, that came up. Screening for depression, offering appointments, but we've offered appointments. That was the whole idea behind coming here, that we could actually offer patients access. It doesn't matter if they're carers or not carers, it doesn't matter. I mean, or whether they've been in the army or served or whatever, I think everybody should have good access to primary care. And no matter, if whatever their occupation or what they're doing. I was just thinking a bit, if you have to keep an eye on 10% of the practice population, and when it changes, how do you know? You'd have to run surgeries, you have to ring them every time, and you're still looking after this person. If they die, you have to keep things up to date. And it's an enormous amount of work would be to keep a register like that accurate, because the status of care is not something like diabetes that is probably going to stay with the person and have a yearly review. It is something that can change. So people, the other 90%, you'd have to ring on a weekly basis as well and say, have you become a carer? Because how else would you know that people have changed their status? I mean, the amount of work involved, the only thing I could see on the website is that yes, they say we should offer flu vaccination to protect the vulnerable patient or people that carers look after. But then you have an example that children could be carers of parents, and parents could be carers of children. So if you have somebody with a medical condition like frailty or diabetes and a number of other things, it might make medical sense to offer the treatment, the vaccination, to the people around that person to protect them. I mean, ideally, if the vaccine actually works, you'd give it to the patient, but not everybody on your website says responds very well to vaccination. So if somebody has an immunodeficiency problem, the vaccine might not take as well, and yes, it might make sense to reduce their contact with people that potentially could infect them. But the whole reason, I think, behind it, because this flu is a yearly thing, it's a minor self-limiting disease really. Only some people in a high risk group might be at risk of complications, so fair enough, we should vaccinate people on medical grounds. The problem is a little bit I have with vaccinating carers for flu is that we're not doing it on medical grounds. We're not protecting the person that is actually getting the vaccine. And so that, I think for me, is an important principle. It's an Orwell problem again. Because I think if you go that far, then what's the next step? We keep the DNA of everybody, and once somebody needs a kidney transplant, it would be more economically viable to give them the kidney transplant than to keep them on dialysis. So you get a call and say, sorry, we need your kidney, and now there's somebody who needs it. I mean, if that's acceptable, then fair enough, but I think in society we should maybe offer treatment to people if they want it or not, rather than trying to target people and sort of morally blackmail them into accepting what is a medical treatment, flu vaccination. Then there's a thing in your handbook here, which I didn't quite get. It says older people, there's a new enhanced service on the new GP contract to support GPs and practice staff, provide proactive care for 2% of the adults, thing, blah, blah, blah. Now, I didn't think this was a very useful way to spend my time, but probably a lot of money, so I think a lot of practices have taken it on out of financial consideration. When you say on this in your handbook note, not all practices have been contracted to provide this new enhanced service, because in your previous report we were criticized for not doing this. That's what it says here, that's how I read this here. However, the absence of a contract for the service should not affect the rating given. CQC judgments are based on the quality of service provided for people and not on contractual adherence. So what I read it a number of times, but what it means to me is that even if we're not contracted to provide a service, we should still be responsible for the quality of that service. Is that my correct reading of it? Are we being judged on something we're not contracted, not paid for to provide?
Let me go a step back first. You didn't sign up to this service.
No, I thought it was a waste of time, and I think the CQC then brought out a report to say that it is actually a waste of time as well. But so I didn't sign up, so am I still responsible? If you go and look and ask me later, where's your, what if it's older people, frailty index reviews?
I think the first thing to say, of course, is that from the 1st of April 2017,
I know this year that thanks to the PMA's put in our base contract.
It's gone into the baseline.
Yeah.
So
I resigned from the B&J in 2004 when they brought the contract in. I thought about rejoining so that they could resign again exactly over these kind of things. But anyway. So
it's not within the contractual requirements now. I think, however, the general principle is the one that you espoused early on in your presentation, which is that you desire to provide high quality care to all of your patients. And this group is obviously one of the many groups for whom you're wanting to provide high quality care, and perhaps are a group of high risk patients. And one would expect to see within the discussion that we had that you were providing quality care to this group as well as others.
We are providing the same quality care to everybody, whether they're in a frailty thingy or not, whether they come out of a surge or not. It doesn't really make any difference. So, but the reason for this here wasn't that, it was that this program, this scheme and the enhanced service was to reduce admissions. Initially it was called the admission reduction scheme or whatever it was called. And so again we're back to a financial incentive to do things, and I'm not really driven by it. So if I don't sign up to it, then it's really up to the CCG to commission it from somebody else. So So it's no longer my responsibility. And I can't be judged on something that is not my responsibility. You have to go to the CCG and say, you know, Dr. Beer said you hadn't signed up to this service. Who have you commissioned to provide this service to the 2% of the people on this list that are so frail and are at risk of admission? They can't blame me for that. But this here reads as if you're saying, well, it doesn't matter, you know, you're not responsible for it, we're still going to judge you on it. The same thing with the out of hours. I just changed the elder service to out of hours. It's an old enhanced service. We opted out. I can't be held responsible for the quality of the out of hours if I'm not being paid or not providing it. You have to go to the out of hours services. That's what you do. You don't come to GP surgeries and say, hey, you know, people had to wait 4 hours last night to be seen. That's not me. So strangely enough, on your website and handbook, it also says, you know, on the other hand, for families and things, you say, we consider specific service provided by practice or registered CQC, regulated activities, and if they're not providing it, you're not regulated, we can't judge you on that. So that seems to contradict the other thing you put in the handbook. And then the learning disability. So there's another thing that we were marked down on in our previous report. So we looked for a learning disability register, etc. Again, £114 I think is offered for each completed check. I think this year going up to 140 quid. Now I said I don't think this is very useful not a very useful way to spend my time. And so I haven't opted for it. So again, you have to go to the CCG and say, who have you contracted to provide this valuable service to the learning disability people on my list? Again, so if a practice is not providing this enhanced service, we expect them to still provide it. Is what you say in your handbook. It doesn't make sense to me. It makes sense. So either provide it or not, it can't be held responsible for it. Although we accept, this is some things out of the report and the merged file, so we do accept that the practice does not participate in the enhanced service. We do expect them to do the work. That makes sense. Then we have vulnerable 2% thing that's been written in, thank you to BMA, into our contract this year. So the right thing. And again, you say we can target certain groups, learning disabilities, homeless, gypsies, migrants. You can carry on, but I again, out of principle, I don't think I want to keep registers like that. I don't know what happens to those data. They're extracted from our computers, except for me. I had a letter from Professor Sergio or something from NHS Digital saying we're the last practice that this data is not collected from, for some reason or the other. But I don't think, unless we know and unless the patients agree to these data being extracted, that we should just hand it over. And again, it's George Orwell. Yeah. This here is in your report. We've been asked to report on this, the male GP issue. Again, I have a bit of a problem, actually not that much of a problem with it. Some of the emails that throughout the updated report submitted as factor accuracy, Dr. B makes constant reference to his willingness to undergo gender reassignment surgery in order to fulfill our requirements. Do you know how many times it has been mentioned in the annotated report by Dr. Bierstecher constantly? One time, okay. And the other thing that's wrong here, you can see, is that reassignment surgery, the person who wrote this email has no idea about gender reassignment, because surgery is not required to get gender reassignment. Just because I'm standing here with traditional male things in the trousers and the shirt and the tie, doesn't necessarily mean that I'm actually a man. Even though I shave every morning, even though I might have the genitals in my trousers of a man, it doesn't necessarily mean that I'm a man. If something goes wrong, can we get an apology? Maybe, maybe not. Effective. Are we discriminating on gender? So I think because at the moment I think the idea is, I saw in Nigel Surgery wrote something last year, maybe because of the video on YouTube, maybe not, who knows. But instead of putting in, the practice did not always provide the patient the choice of seeing a female GP. That's been put in a lot of single-handed male practice reports. You'd have to go back a long time to edit them all out. But the 3 all-female practices around here that I looked at their reports, none of them had this remark to say the patients did not get a choice to see a male GP. So it is a bit strange how you then, in Nigel's surgery, give the example on all-female surgery. This is not what you've been doing in the past. Gender doctors, so it's written in now Nigel's surgery 78, if patient feedback showed the need for a gender mix. So I expect in the GP patient survey to appear 2 new questions. Do you have a choice of gender GP? And if yes, would you like the same gender GP? Now you have to probably be pretty gay if you're a man and there's an all-male doctor or an all-female practice to say, I want to see a male doctor. You think, which man is going to answer that question? Are you gay or not? So if you just replace gender with maybe, race or something, do you have a choice of same race GP? Do you want to see one that isn't black? So if Nigel and Field are serious about it, just think about that, how that would sound if you're planning to do this. Yeah? It's the same thing, gender, race, whatever. This report, when can I see it? And it says, England team fully expect concern about engagement. I've asked for the report and be able to see it. Now, how can I respond to a report or concerns that I don't know about? I don't know. Can I
just interrupt for a moment, because some of these issues here I can see from the factual accuracy process on the previous report, which is now closed.
No, it isn't. No, it isn't closed.
With your data requests made to our central office, we're here today as an inspection team, so I think we need to focus on this inspection and moving forwards, because we will have different teams within the Care Quality Commission who will respond to these.
Yeah. So here's the things at the bottom of the merged document, things I needed to do. The practice was unable to demonstrate that a business continuity plan for major incidents, which we had submitted, but it's got lost somewhere, I think. But anyway, it's been provided. The pads on the DFAB were out of date. They had actually already been ordered when you came, but they were out of date by a few months. The reason is they weren't on our schedule for equipment, so we've added them in. And we've also since then have revised a new schedule. Now we put everything that comes in, so it's work in progress, because there's so much equipment, it's hard to keep on top of it. But now we're adding all the new equipment with expiry dates onto the manager's Outlook, so that you get an appointment or warning a month before something runs out, and that's probably going to help us to stay on top of it, because so there's just too much equipment and things to keep an eye on. I mean, what might be useful for this CQC maybe, I can't imagine I'm the only practice, so there's another practice down the road that pad's out of date, not mentioned, but so we're not the only practice that have slip-ups, and I think slip-ups are unavoidable really. The only thing we can do is try and reduce the risk of slip-ups, and so the CQC probably knows, which things work in what practices. I mean, what is useful? Do you produce a list and say, these things we found that works in the practice? Otherwise, you're expecting 8,000 practices to all invent the wheel all over again. And it would be handy, that would be handy. I mean, if Nigel Surgery says, this could do, I'd subscribe to it. Vaccinations without patient group directives. We have read up on the Health and Social Care Act 2012, and it looks like the Medicines Act of 1968 was being breached by all practices. And that's why I was going by the old guidance of the BMA and the GPC, that these things were for community really rather than for general practice, because general practice has a list of patients was the old idea, and that therefore, because they're on a list, they don't need and sort of act as a PSD rather than the PGD. But if you read the legislation to the last letter and the acts, and it does look like everybody was probably in breach of it until some years ago. So we've got a whole heap of PGDs now upstairs in the office. Hasn't changed much, but we've got them, I think, signed up, 16 or so of them, with dates on them, and to keep an eye on as well when they're running out of date. No systematic approach to clinical governance. You wanted us to change that, but it had been withdrawn, so that really didn't apply anymore. The other thing you required us to change was the current policy that clinical and electrical equipment was actually maintained, but that had also been withdrawn in the merge document above. So probably the fields weren't updated, is my guess. Yes, no, maybe. Is the other thing on the requirements practice must do to change quality policy, failed to ensure that the information gathered was analysed and responded in timely fashion, action to address these significant events. I think we had one significant event that I'd half finished and filed and forgot to go back to. But anyway, we did a review of it and our methods, and most of the time it works, but said we can't always have 100% achievement on everything. It's not possible. Human error is the problem. So we've reviewed it, and we're doing our best. That's all I can say. No procedure to ensure sufficient and suitable people could be deployed to cover emergency and routine work if the practice manager, nurse and the GP were both all expectedly absent. So we did have a business continuity plan, and I said there wouldn't be any different. Apart from that, and we demonstrated it in the past. We have telephones, and we can still ring the reception and instruct them to do things. If they need our guidance, if we're stuck on a plane or whatever. But again, it's probably events that you can't always predict. The only thing I suppose that I've done since then is not taken any holidays since January 2016. If that may be a solution to it, I don't know, maybe. We found staff who acted as chaperones had not had DBS checks, but again, that wasn't really required for us. So I don't know. That will be something we should review, and we've written a policy. And that's the end of it. That's today's surgeries, where you see the black things are where we are now at the time. Okay. 10:27. I think I'm booked at 10:20 or so there's probably patients waiting at the moment.
Okay, so thank you very much for that. I wonder if we could have a copy of that presentation. Yeah, that's okay. And as we said earlier, the plan is for Dr. Ian, my GP specialist advisor, to have a chat with you when you're free. So what time would that be? At the moment, the 2 appointments this morning, this is from Sunday night, and been booked, but 2 other ones have been booked, but nobody else wanted the last one until now. I don't know, if I walk out of there, it might be a different situation. And tonight the appointments that are there in green are booked up, and we managed to shift Alison's appointment all after 5:30, because I think your schedule said at 5:30 you wanted to have a meeting or something. So we don't know exactly what happened in between, but it's a problem a bit if we're still expected to work, so we could close the place. Seeing patients for two patients?
Maybe 4. It'd perhaps be helpful if you could check the live list, and then we can arrange when we can.
Yeah, I mean, it's probably okay.
Well, generally, if anybody's booked in, it goes orange. It doesn't.
No, this is a screenshot from Sunday night.
Oh, the Sunday. All right, sorry. Okay. Do you wish me to check with them?
No, it's okay.
Okay.
So it would help me to know how many patients they see.
Because I would be 4.
Well, do you want to check, see how many people?
3.
So I'll probably
Yeah.
catch up with you in about 40 minutes, something of that sort of order.
Yeah, I always gone late, so I
yeah,
don't know.
take your time, whatever's necessary, and I'll follow on from there. Okay, so I'll keep out. Goodbye.